The geometric approach requires a prosthetic plan diagnostic guide that is evaluated with a cone beam radiograph to determine if any linear or angle corrections are necessary. Corrections are used to reposition the surgical guide in any of 8 different anatomical directions of the tooth. Linear and angle corrections are used to fabricate a new surgical guide if necessary. I'm going to examine the images of the diagnostic guide with 3 different software programs. We will be replacing the mandibular left central incisor. The treatment plan is to place the implant in the number 24 position and to move number 25 lingually while the implant integrates. The first step in the GuideRight protocol is to fabricate the diagnostic guide. A 3/32 drill in the number 24 site is used to prepare the planned osteotomy. A straight 2-piece guidepost is placed in the osteotomy to fabricate the diagnostic guide. This illustration shows the 2 mm top part, the 2 mm guide sleeve, and the straight 2 mm guidepost used to fabricate the diagnostic guide. First, the cast is lubricated with petroleum jelly, and triad gel is added to capture the cleat in the adjacent teeth to form the diagnostic guide. The guide is placed in the patient and the cone beam x-ray is taken. 3 different software programs will be used to evaluate the surgical guide for any corrections needed to place the implant properly. The next step is the alignment of the arch in all 3 programs. The home position is demonstrated. It is the cross-sectional mesial distal view of the implant placement. The illustration on the right shows the merging of the model. The green line illustrates the position of the osteotomy created with the 3/32 drill. The home position occurs when the long axis of the implant is aligned with the radiolucent center of the guide sleeve. Since the virtual implant and the guide sleeve are aligned, there is no need for a mesial distal correction. A 3 by 12 mm virtual implant has been selected for this case. The position I have selected for the implant will require a 12-degree correction as measured with the protractors in the software programs. The correction will be made using the straight guidepost and a 12-degree angle. A 3 mm top part will be used to align the 3 mm guide sleeve with a straight guidepost. These are the components of the GuideRight system used to make corrections to straight or offset guideposts. Corrections can be made in any of 8 different directions, according to the anatomical surfaces of the tooth. The stylus securely holds the guidepost while it is being corrected. The cap screw securely holds the guidepost when it is placed in the bending block. The plate has a protractor scale marked in 1-degree increments. There are 2 hex drivers, one to tighten the cap screw to hold the guidepost. The 0.035 driver fits the set screw in the stylus. The stylus support bar is used to support the stylus when a second correction is made in a plane 90 degrees from the first correction. In order to make an angular correction, the guidepost is placed in the stylus with a registration dot exposed. A set screw, which can be seen in this illustration, is tightened against the side of the rectangular platform of the guidepost to make accurate corrections. The stylus with a straight guidepost placed in the bending tool block should register at 0. We are making a 10-degree bend to a 2-piece guidepost with the GuideRight bending tool. Since no offset is required, a straight guidepost is selected for this case. The stylus is rotated until the slot is visible to place the rectangular platform of the guidepost. The set screw is tightened against the guidepost with a 0.035-inch hex driver. The set screw in the stylus is tightened to secure the guidepost in place. The octagonal guidepost shaft is placed in the hole in the bending tool block. Now the socket cap screw is tightened against one of the flat surfaces of the guidepost. In this case, the top of the stylus can be removed to the right or the left to make the 10-degree correction. The socket cap screw is loosened and the stylus with the guidepost is removed from the block. The set screw on the stylus is loosened to remove the guidepost. The guidepost with a 10-degree correction is removed from the stylus. The Pythagorean theorem can be used to determine if a 1 or 2 degree error is clinically significant. The clinical difference between an 11 and a 12 degree angle at the apex of a 10 millimeter implant is 0.2 millimeters. This slide illustrates the steps taken to make a compound bend, where you work in one plane, and then after one plane you have to make a correction in the second plane. You need to review this at your leisure. After the guidepost has been corrected, the next step is to make the surgical guide. The guidepost with a 12-degree correction is placed back in the model, being sure to orient the angle toward the lingual to make the correction in the surgical guide. A 3 millimeter top part of the 2-piece guidepost is placed on the lower part, and a 3 millimeter guide sleeve is placed on that part, with the brackets oriented toward the lingual to be captured in the triad gel. The cast is first lubricated, and the triad gel is added in layers and cured briefly so it doesn't run down the inside surface of the cast. A stereolithographic guide was also printed using the Blue Sky software. Using a 3 millimeter guide sleeve, it was placed over the guidepost to see how they fit, and it fit very well. Finally, we are ready to place the implant. An elliptical incision is made with lingual flap reflection. When the surgical guide is inserted, it holds the flap out of the way for the preparation of the osteotomy. A 1.6 millimeter press fit insert is inserted into the 3 millimeter guide sleeve to center the initial 1.5 millimeter drill. Next, we're inserting a 2.3 millimeter insert for the 2.2 millimeter drill. Since the implant carrier is larger than the 3 millimeter guide sleeve, the implant has to be placed freehand into the osteotomy. To evaluate the implant placement, a postoperative cone beam was taken. A small field postoperative cone beam was taken to show the final placement of the implant. The 3D rendering illustrates the inadequate facial bone profile. To facilitate the bone grafting on the facial surface, a vertical incision was made to use the VISTA approach for onlay grafting. A small osteogen plug was cut into 3 sections. 75 micrograms of BMP2 were rehydrated with sterile water and added to the osteogen. The sponges saturated with BMP2 are placed in Pyros and allowed to set for 15 minutes prior to use. After the absorbable collagen sponges with the BMP2 are placed under the flap, the sites are closed with 5/0 nylon sutures. For a better understanding of the use of the bending tool and the use of the 2-piece guidepost, go to www.slideshare.net/C Meitner.